person and ladies and gentlemen. The physiology-based discussion on this very important topic. Slides are not moving. All. So, most important point that I would like to highlight is 50% of angiogram are read wrongly in left main lesion. And that is being proven by the study. And LMCA disease, 70% are associated with TVD. And if you do inappropriate stenting in the left main, event rate, even when you do appropriate, it is 20%. So inappropriate is a very punishing judgment. So there is a study done of eyeballing reading of the left main lesion. It clearly shows that 40% mismatch and 56% inter-individual variability. So start using FFR and IFR is the most important thing. Now, provisional stenting done, and you can see there is a carina shift and tight stenosis in the circumflex side branch, which was highlighted by both the speaker that it's very difficult to evaluate side branch stenosis, better to do FFR, and FFR post-stent was normal even after 8 months. So in intermediate grade stenosis, FFR and IFR, both class 1A level. So both are used commonly and studies have proven that they are good. IFR in fact is superior. So the AUC, appropriate use criteria, has recommended FFR 0.75 and IFR 0.85 or non-hyperemic indices 0.85 are ideal 100% safe. In between the two, the cutoff and this particular reading 0.75 and 85 is very important that you remember that. So it's useful, studies have proven FFR evaluation, and in case FFR is not determining, then better to use IVUS because it very well correlates with 0.75 FFR and 5.9 millimeter MLA of the left main. So recently criteria revised that revascularization of left main lesion, if it is MLA less than 0.45 or equal to 4.5 and more than 6, no revascularization, and FFR in between 4.5 and 6. So these are the 5 situations that we can face: the isolated LM lesion with total RCA or severe lesion in the RCA, providing collaterals to the RCA, LM with LAD stenosis, LM with L6 stenosis, and serial stenosis and LAD L6. So we have to take care of pitfalls that we all remember. So when we have a fractional flow reserve assessment in left main stenosis in presence of downstream coronary stenosis, it's very important to remember FFR true, FFR apparent, and FFR epicardial. So this is the true FFR because downstream there is no lesion. So pullback or FFR evaluation will tell the true FFR. When there is a downstream lesion, then FFR done in the post-distal lesion is an apparent FFR. If it is less than 0.75, definitely treat it. If it is equivocal, then we require a epicardial FFR, and that is done by pullback. Defer is not safe, it is less than 0.5 epic FFR. If it is more than 0.75, defer safe. So this is very important, and more than 0.85, definitely defer it. So if you have a distal lesion, first treat the distal lesion, and after treating the distal lesion, you can get a true FFR again. So you can see here that the FFR in the first lesion was 0.84 in between the two lesions. But post-stenting, it's critical, 0.74 requiring revascularization. So when it is a single unit, you can do a FFR or IVUS both and decide whether to treat or not to treat. And when it is associated with downstream lesion in both the vessels, it's better to do a pullback. And when we have a serial lesion, then it is a complex equation that you have to play through and get the true FFR in both the lesion. So interaction of two stenosis FFR in each lesion separately cannot be calculated by equation. Isolated stenosis cannot be like isolated stenosis, but it can be predicted by a more complete equation taking into account the pressure, aortic pressure mean, pressure distal, and pressure wedge. When you have a diffuse disease, you can do a pullback pressure gradient, and this has been very clearly coming up an emerging metric, which is very much into consideration, especially when we see a very lot of diffuse disease, elderly patient, focal disease, diffuse plus focal combined, and that helps us in deciding whether this requires a stent or not. If stent is done in a diffuse disease, the long-term results are not good. So in conclusion, PPG, the pullback pressure gradient index, is a null metric, an emerging tool that provides quantitative measure of focality or diffuseness of the disease. It provides a precise description of longitudinal distribution of atherosclerotic plaque, enables clinicians to predict symptomatic response, residual ischemia, and potentially target the vessel failure in patients undergoing PCI. So in summary, I would like to say that if you measure FFR, and if it is, as I said, if it is beyond 0.85 and 0.8, you can differ easily. But less 0.75, you have to treat as per the appropriate use criteria. And for IFR, 0.85, you have to treat. So measure FFR in the disease vessel. When you measure the FFR in a disease vessel, LM, LAD, LCX, if it is less than 0.6, then you can stent it, the relevant lesion, and then do FFR. If it is more than 6, then we can do IVUS and decide whether we need further treatment. In a case where FFR and IFR both are not giving good discordant or borderline reading, then we can do IVUS. And between the 3 reading, if 2 are significant, we can do an intervention. There's another post-stenting FFR. That is, this is very important these days. If stent under expansion is 40% nearly, so you have to post-dilate. If you find FFR is significant, then residual stenosis, if you find FFR, focal FFR step up 0.5, then you need to add stent. Then another repeat pullback, and same thing you have to do, add stent or do a post-stent inflation, again high pressure inflation, and clear all the lesion. So in summary, I would say that if your isolated lesion, borderline lesion, if it is associated with ICA total, then revascularize RCA. LAD, LCX, revascularize distal lesion and see the FFR and decide whether it requires or do IVUS along with it. Use IVUS in ACS, that goes without saying because FFR is not going to be reliable. And post LM-LAD, use FFR to decide LCX stent. So in conclusion, it is saying very clearly that IFR is more reliable in left main lesion and serial lesion than, because it's not flow related, so it doesn't give any interaction between the two stenosis. And in aortic stenosis, IFR is more reliable because it's not flow related and should be considered that. And this is what it is saying. And thank you very much for coming.